Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Naha Balada from Roots Community Health, reporting for the week of August 25th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After an update on COVID illness status, I'll provide an update on the measles outbreak, on COVID vaccine availability, and the crisis status of public health in general. First, starting off with the proportions of respiratory viruses detected in a clinical setting, it is still primarily rhinovirus, enterovirus, followed by SARS-CoV-2. SARS-CoV-2 continues to make up an increasing share of those viruses, even though we know that many people will test at home. And so this is for those who go into a clinical setting, but still increasing in terms of its proportion. Taking a look at wastewater, well, we can't take a look at wastewater data because it has actually been paused. We have not had any update for the past couple of weeks, and it is pretty vague, saying that there's some kind of technical issue. And so we do not see the COVID national wastewater data, which is pretty unfortunate given that we are in the midst of a summertime surge. But we can take a look at COVID epidemic trends, and we can see that the majority of the country is growing in terms of COVID epidemic trends. And this is based on emergency department visits for COVID. There are some that are likely growing, but the vast majority in that dark purple are growing, and a small handful in the gray are not changing. So we don't really know which direction they will head next, but nowhere at this time is actually declining or likely declining. And when we take a closer look at emergency department visits broken down by age, we'll see something rather concerning here. I know that we've been concerned about the fact that the majority of, or the largest share of emergency department visits for COVID has been in our 0 to 11-year-olds in that dotted yellow line, which is already quite concerning. But now we also see that the 12 to 15-year-olds and the 16 to 17-year-old groups have actually surpassed the 75-year-olds. And we can take a little bit closer look at that here and see that now the 75 and up age group is actually fourth in terms of its share of emergency department visits for COVID. And so this is definitely hitting our young people significantly. And this is a huge concern, especially given the things I will cover shortly here regarding COVID vaccine policy. But first, taking a look at hospitalizations, we can see that those are ticking up still, not anything too dramatic. It is a slow rise, but again, it's important to note that each state is different. So if you're interested in this, there's a big variability, and you can check on the link in the post and you can see in your state what might be going on. And some are definitely getting hit harder than others in terms of increases in hospitalization from SARS-CoV-2. And we take a look at deaths, we can see that there were 174 deaths the week ending July 26th. And so we've been under 200 since early June, under 200 deaths per week since early June. Certainly hope it stays that way. It's ticking up just ever so slightly, but with hospitalizations and emergency department visits going up, we may expect this to go up as well. But if it doesn't, if it stays low, then we know that we are seeing something that we've been hoping to see for some time, which is that cases can go up without having huge increases in deaths. So that would certainly be a positive development. So this is something that we will just continue to keep an eye on. But so far, we are still at all-time lows for the entire pandemic, and we have been at under 200 deaths per week since early June. Now for a brief update on measles. We have been experiencing the largest measles outbreak in 33 years. We have 1,375 cases reported so far. That's through August 19th. And this is already 4.5 times what we had the entire year of 2024. And already 173 of those individuals have been hospitalized. And the vast majority of these cases are outbreak associated. So they're due to local transmission here in the United States. But in some good news, the Texas outbreak has been declared over. This outbreak started in January 2025, continued on for about 7 months, but there's been no new cases in this outbreak reported since July 1st. So that is 42 days, which is about double the maximum incubation period of measles. So that means the longest time it typically takes between when a person is exposed to measles and when they get sick is 21 days. And now that we have gone for double that period of time without any new reported cases, they are declaring their outbreak over. In that West Texas outbreak, there were 762 measles cases, 99 people were hospitalized, and there were 2 fatalities in school-aged children. So that is devastating. And the outbreak also spread to neighboring New Mexico and killed an adult there. This was the largest single measles outbreak in the United States in about 25 years, so connected to linked cases essentially in one area. This is the largest single measles outbreak in about 25 years. Remember that in 2000, measles was declared eliminated in the United States, but as we know, that is not a permanent status. That's something that we can lose if we don't maintain population immunity. And we know that we have below our thresholds for population immunity in many places in the United States and declining. So the end of the outbreak is a bit of good news, but certainly no reason to let our guard down. And I say that for a couple of reasons. One is because we know that there are still many people right there in Texas and beyond who are susceptible because they don't have immunity. The kids have headed back to school since the outbreaks end, which means more mixing. So there's nothing to say that there can't be another outbreak in Texas or beyond. And there are currently ongoing large outbreaks still in Mexico and Canada. So there's ongoing risk related to travel as well. And as I covered a few weeks ago, school vaccination exemptions are continuing to increase. They've never been so high. And vaccination rates for incoming kindergartners continue to fall in many areas, having dropped below the level that we need for community immunity. So this may be a slight reprieve, but we are definitely not out of the woods. Healthcare providers, teachers, parents should be sure to familiarize themselves with measles and how it shows up. The early warning signs can look like a lot of other infections with fever, cough, runny nose, fatigue. But then comes that classic measles rash, which I personally and the vast majority of my colleagues have only seen in textbooks because, again, it's been eliminated for over 2 decades now. But we will need to, unfortunately, familiarize ourselves with this. The rash can actually also look like a lot of other rashes. It's kind of flat red spots that then become tiny bumps. But one of the biggest clues, the measles rash, is that it typically starts up at the hairline and then makes its way downward, spreading to the face and the neck and then the body. The measles vaccine is highly effective, but remember the first dose is not typically given until 12 to 15 months of age, leaving our under 1-year-olds susceptible. And if you've got it between a 12 and 15-month-old, I might err towards that 12-month, depending on where you live, especially. But really, they are completely susceptible without those vaccinations. And the second dose is given between 4 and 6 years of age, at which point it's thought to be in the high 90s, estimated 97% effective, which is being put to the test right now, but that is still quite excellent. Remember that if you're going to be traveling internationally or to a place experiencing an outbreak with an infant between 6 and 12 months of age, it might be recommended that an early dose be given just to give them added protection. So please talk to your pediatrician or travel clinic, and also plan to get this completed at least 2 weeks before your travel. Now for an update on the COVID vaccines this year. So we've just talked about, we know that COVID-19 activity continues to pick up. We are in the midst of a late summer surge. Students are heading back to school, which we know increases mixing and can drive increased transmission. So I've been getting a lot of questions about the COVID vaccine. When will it be available? How accessible will it be? So as a reminder, the FDA's Vaccines and Related Biological Products Advisory Committee, VRBPAC, met in May, and they voted to recommend a vaccine formula that targets the JN.1 variant. Specifically, they say it's preferred to target a strain called LP.8.1, which was based on the variety of SARS-CoV-2 that was circulating at that time. Right now, the dominant strain is XFG, which is a hybrid of two Omicron strains, including one that is related to the LP.8.1 variant. So we're still talking about the Omicron family, but our strategy continues to be updating the vaccine to get the closest match possible to the currently circulating variants. And that is also the case for this year, for the 2025-2026 season. I have not heard anything definitive, but the expectation seems to be that the new vaccines will be available in the fall, maybe next month in September. And this timing is aligned with what has been done the past couple of years in an effort to synchronize the COVID vaccine and the flu vaccine campaigns. But having said that, I will note that the updated 24-25 vaccines are still considered effective. And if that is the choice that you have, if you're overdue, if you need one and you can locate them that are unexpired, it still will provide valuable protection against severe disease. So this is just something to keep in mind, especially with all of the uncertainty around the availability and approvals. In prior years, the recommendation has been for everyone 6 months and up to receive a COVID vaccine, just like the recommendation for flu vaccine. And then also for those 65 and up and those with immune compromise, the recommendation has been for an additional dose. So really an every 6-month schedule. Now, as we have been trying to track here on the People's Health Briefing, new guidance has emerged through unusual channels like social media and website changes that seems to limit access to pretty much everyone except those 65 and up and those with certain underlying conditions. And like I said, these new guidelines have been communicated through updated websites and through social media instead of the usual transparent process that we've come to expect from the CDC and its advisory committee. And this has led to a confusing kind of public back and forth between individuals without medical background and professional organizations with actual expertise, like the American Academy of Pediatrics and the American College of Obstetrics and Gynecologists. We've even heard rumors that the Trump administration is planning to completely ban the COVID vaccine within months. For now, it is a rumor making headlines, so who knows where the truth actually lies. But this is very much in line with the haphazard, fact-free decision-making that has marked 2025 so far. The perplexing part about it is that we've heard for years now from the same individuals making these decisions about how it's all about choice. We shouldn't be forcing anything. So obviously banning something and removing choice seems logically inconsistent, even with the administration's own rhetoric. So I'm certainly doing my best not to react to everything I see in the headlines, even if it is coming from the highest levels of government, because at least in theory, there are still more steps that have to be undertaken before life-saving vaccines can just be banned, or at least we can continue to hope. In the meantime, remember that the list of conditions that make a person at risk for a poor outcome from COVID is actually a very long list. So make sure to familiarize yourself if you're not sure. It's very possible that you and your loved ones can find yourself on that list. And it's very important that you have a primary care doctor that you could discuss this with so that you can receive the best protection for you and that you'll be prepared no matter what may come. One of the concerns with all of these potential policy changes has to do with access and coverage. So even though your doctor may be perfectly willing to recommend and administer the vaccine off-label, pharmacists might not be able to do that. Insurance companies can then choose not to pay for it. Establishments might stop stocking it. And so all of this leads to decreased access and is very concerning. I will say so far, though, that we have not seen any insurance companies not cover it, which stands to reason. I just showed a graph of emergency department visits for COVID. Our children are being hit disproportionately hard in terms of COVID sending them to the emergency room. Getting sick enough to go to the emergency room with a respiratory condition is concerning, and we know that vaccine reduces the risk of this happening. We also know that insurance companies would rather pay for a vaccine than an ER visit, or even worse, a hospitalization or ICU stay. So that is a potential silver lining, since they're often going to base insurance coverage on cost considerations. So we'll just continue to pay attention to what is going on. I do feel a little reassured seeing some of our professional associations really stepping up in this moment. Even though they might not have the power to require insurance companies to cover things, insurance companies can certainly choose to follow those guidelines because they are above and beyond what the government is requiring. They're going to be consistent with their cost considerations, and they are clinically sound. Having said that, if there is any kind of ban or prohibition on these vaccines, we will be having a different conversation. So more to come on this, I am sure. I wanted to share a couple of other critical updates. First, 600 employees at the CDC have been permanently fired, and this is across a number of different departments. This reportedly includes about 100 people, in the Division of Violence Prevention, so the entire Division of Violence Prevention. So this is coming just weeks after a gunman opened fire at the CDC's headquarters in Atlanta, killed an officer, and this is just a very cruel irony, and really is concerning because we know that gun violence is a public health crisis in this country, and so wiping out the entire division speaks volumes. In other sad news, the state of Mississippi's public health department declared a public health emergency last week in response to their increasing infant mortality rate. Infant mortality rate is actually increasing across the entire United States, and Mississippi is experiencing one of the highest infant mortality rates in the country. So infant mortality is one of those indicators that we actually use to determine the health of entire nations. And having an increasing infant mortality rate is something that certainly speaks to the health of our nation. So when we put all this together, we are seeing gutting and dismantling of critical public health infrastructure. We are decreasing access to life-saving vaccinations. We're seeing a resurgence of a previously eliminated virus. We're allowing our children to be sickened by COVID and measles, among other things. Large parts of the country are becoming increasingly vulnerable to vaccine preventable illnesses. Our infant mortality rates are rising. And then with the passing of HR 1, we are seeing devastating cuts to our healthcare safety net as well. And at this point, there is no indication that any of this will improve anytime soon. On the contrary, it could continue to get worse. So in the face of these challenges, it's just becoming increasingly important that we do what we know we can do to protect ourselves, our loved ones, and our community, and to stay well informed. And this means staying up to date on our vaccinations, seeking accurate information from trusted sources like doctors and professional medical associations, being vigilant about symptoms in yourselves and your children, and just staying alert and communicating with one another when we think we're coming down with something. Stay home, rest, isolate, don't go around others, try to reduce spread, do your part, do what you can. Seek early treatment when needed to prevent those more severe outcomes, and get some rest when you are not feeling well. manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. We'll be taking next week off, and we look forward to seeing you Tuesday, September 9th at 10 a.m.